Why does the mere mention of a chest X-ray evoke a sense of urgency and precision among health professionals? It's because this seemingly simple image harbors deep insights into human health, revealing secrets hidden within the thoracic cavity. To embark on the journey of reading a chest X-ray, begin with a systematic approach. First, confirm the patient's identity and the date of the X-ray to ensure its relevance to the current assessment. Next, assess the quality of the X-ray. Ensure it's neither too dark nor too light and that the patient was in the correct position. Both clavicles should appear symmetric, and the spinous processes should align with the middle of the vertebral bodies. With the preliminaries out of the way, dive into the anatomy. Start at the top. Examine the lungs' apexes, the area just above the collarbones. This region can sometimes harbor lesions missed in less thorough examinations. Now scan the entirety of the lungs. The lung fields should appear clear without any unusual opacities. Evaluate the vascular markings. They should become less prominent as you move from the hyla, the central parts of the lungs, to the periphery. The heart comes next. Its size and contour can be telling. A normal heart should not occupy more than half the width of the chest. While viewing the heart, also note the position and clarity of the diaphragm, which should curve neatly along the bottom of the heart. Do not overlook the bones. Inspect the ribs, clavicles, and the spine for any signs of fractures or other abnormalities. After the bones, focus on the soft tissues. Check for any unusual shadows that might suggest abnormalities in tissues around the lungs and heart. In conclusion, reading a chest X-ray is akin to deciphering a map full of landmarks and pathways. Start with ensuring the quality and correctness of the film. Move systematically from the top of the lungs to the heart, the diaphragm, the bones, and then the surrounding soft tissues. Each step offers crucial insights, and missing even one can be like missing a turn on a meticulously planned route, possibly leading to misdiagnosis or oversight. Understanding the chest X-ray, therefore, is not just about spotting the obvious, but also about appreciating the subtle nuances that could be the key to unlocking vital clinical decisions. Right paratracheal stripe. This is a thin vertical line to the right of the trachea. Significance. It represents the interface between the right upper lobe of the lung and the mediastinum. A widened right paratracheal stripe, greater than 4 mm, can indicate lymphadenopathy, mass, or infection. Aortic knob. This is the rounded prominence seen on the left side of the mediastinum. Significance. It is the contour of the aortic arch. Enlargement or abnormal contour of the aortic knob may indicate aneurysms, atherosclerosis, or other vascular abnormalities. Pulmonary trunk. Located to the left of the midline and below the aortic knob, it appears as a round prominence. Significance. Enlargement of the pulmonary trunk can suggest pulmonary hypertension, congenital heart disease, or other cardiovascular conditions. Left atrial appendage. A small outpouching from the left atrium, seen below the pulmonary trunk. Significance. Enlargement of the left atrial appendage can indicate left atrial enlargement, often due to mitral valve disease or chronic left atrial pressure overload. Para-aortic line. A vertical line representing the descending aorta against the left lung. Significance. It should be straight. Abnormalities or deviations may suggest aortic aneurysm, mass effect, or pathology adjacent to the aorta. Left ventricle forms part of the left heart border, typically seen below the left atrial appendage. Significance. Left ventricular enlargement may suggest left ventricular hypertrophy, heart failure, or cardiomyopathy. The left ventricular border should be smooth and not overly convex. Paraspinal line. Vertical lines adjacent to the thoracic spine, representing the interface between the lung and paraspinal soft tissues. Significance. Displacement or blurring of these lines can indicate paraspinal masses, infections, or vertebral fractures. Azygoesophageal recess. Located just to the right of the midline, this area represents the interface between the azygos vein and the esophagus. Significance. Abnormalities in this area can be due to esophageal disease, lymphadenopathy, or masses. It's crucial in assessing conditions like hiatal hernia or esophageal carcinoma. Right atrium. The right atrium forms the right heart border, visible on the right side of the mediastinum. Significance. Enlargement of the right atrium can suggest conditions like tricuspid valve disease, pulmonary hypertension, or chronic right-sided heart failure. Interlobar artery. Part of the pulmonary artery, visible within the lung fields, primarily the right upper lobe. Significance. The size and shape of the inner lobar artery can give clues about pulmonary arterial pressure. Enlargement can indicate pulmonary arterial hypertension or other vascular abnormalities. Right paratracheal stripe, normal appearance, thin, less than 4 mm. Abnormal findings. Widening can indicate lymphadenopathy or mass. Aortic knob, normal appearance, smooth and round contour. Abnormal findings. Prominence or irregularity may indicate aortic pathology such as aneurysm or atherosclerosis. Pulmonary trunk. Normal appearance, small round prominence. Abnormal findings. Enlargement suggests pulmonary hypertension. Left atrial appendage, normal appearance. Small outpouching, not prominently visible unless enlarged. Abnormal findings. Prominence indicates left atrial enlargement. Para-aortic line, normal appearance, straight vertical line. Abnormal findings. Bulging or deviation may suggest aneurysm or mass. Left ventricle normal appearance, smooth, forms part of the left heart border. Abnormal findings. Convexity or enlargement indicates hypertrophy or cardiomyopathy. Paraspinal line, normal appearance, thin, straight lines parallel to the spine. Abnormal findings. Blurring or displacement indicates mass effect or vertebral disease. Azygoesophageal recess. Normal appearance, small space, usually not prominently visible unless pathology present. Abnormal findings. Changes suggest esophageal or azygos vein pathology. Right atrium. Normal appearance, forms the right heart border. Abnormal findings. Enlargement indicates right atrial hypertrophy or failure. Interlobar artery. Normal appearance, thin, consistent with the pulmonary artery size. Abnormal findings. Enlargement suggests pulmonary hypertension. Check technical quality positioning. Ensure the patient is centered with no rotation. Clavicles should be symmetrical. Inspiration. Adequate lung inflation is important. Typically 9-10 posterior ribs should be visible. Exposure. Proper exposure should allow visibility of the spine through the heart. Examine soft tissues and bones soft tissues. Check for masses, subcutaneous emphysema, or other abnormalities in the soft tissues. Bones, look for fractures, lytic lesions, or other skeletal abnormalities in the ribs, clavicles, and spine. Evaluate the lungs and pleural lung fields. Check for symmetry, masses, consolidation, which may indicate pneumonia, and other parenchymal abnormalities. Pleura. Look for pleural effusions, fluid, pneumothorax, air, and thickening. Inspect the mediastinum and hilum mediastinum. Assess for widening, masses, or shift. Widening may suggest conditions like mediastinal mass, aortic aneurysm, or lymphadenopathy. Hilum. Check for lymphadenopathy, masses, or vascular abnormalities. Assess the diaphragm and pleural spaces diaphragm. Look for elevation, which can suggest phrenic nerve paralysis, or flattening, which can indicate hyperinflation as seen in COPD. Costophrenic angles should be sharp. Blunting can indicate pleural effusion. Cardiomegaly, enlarged heart silhouette. Pneumonia, consolidation, typically with air bronchograms. Pleural effusion, fluid levels in the pleural space, seen as meniscus sign. Pneumothorax, visible line of the collapsed lung with no lung markings beyond it. Aortic dissection, widened mediastinum, abnormal aortic contour. Pulmonary edema, curly B lines, bat wing appearance, pleural effusions, rib fractures, breaks or discontinuities in the rib shadows. Interpreting a chest X-ray involves a systematic approach to evaluating the anatomical structures and identifying any abnormalities. Understanding the normal anatomy and common pathological signs is crucial for accurate diagnosis. For any ambiguous or concerning findings, further imaging or consultation with a specialist may be necessary. Always correlate radiological findings with the patient's clinical presentation.